So first, I would like to thank the organizers of the conference for giving me the opportunity to present our data. The title of the work that I will be presenting is 2-aminotoxy-diphenyl borate, which I'll be calling 2-APB. Neuroprotects the stroke brain through shortening of peri-infarct depolarizations and enhanced perfusion in the ischemic penumbra. Brain stroke is a leading cause of death and disabilities every year, and it is estimated that the number of people living with stroke will increase by 30% in the next 30 years. This progressive increase will affect both females and males. Ischemic stroke accounts for almost 90% of all strokes, and nowadays acute stroke intervention is based on pharmacological or mechanical recanalization strategies. These therapies are limited to the use of these therapies is limited to the first hours after the symptom onset, and as a result of which very few patients get benefit from them. I would like to remark that the longer it takes until a patient receives thrombolytic treatment, the greater will be the extent of the damage. So currently, research is focused on the development of molecules to target the acute phase of a stroke, and a large number of neuroprotective drugs have failed at the clinical level. In fact, there is just one molecule that is in use nowadays, which is called edaravone. It's a scavenger of free radical species, and its use is limited to Japan and China. Other promising molecules, such as NXY059 and NA1, have failed at the clinical stage. So for that reason, it is clear that more research on neuroprotective drugs is needed. 2-APB is a modulator of calcium dynamics through the inhibition of various types of calcium channels. It has been reported that 2-APB reduced neuronal death after oxygen glucose deprivation by antagonizing the calcium entrance through transient receptor potential channels 2 and 7. Another studies suggested that 2-APB exerted a thromboprotective effect in a model of transient ischemia through the antagonization of store-operated calcium channels in platelets, inhibiting their procoagulant activity. So since most patients are not eligible for the treatment with recanalization therapies or are refractory to them, we wondered how if 2-APB had a neuroprotective effect in the case of permanent ischemia. To test that, we used a stroke model based on the permanent occlusion of the middle cerebral artery at the distal level from the Willis polygon. This was performed using a non-consanguineous mouse strain, which we might address for the genetic variability observed in human population. And in our hands, the permanent occlusion of the middle cerebral artery causes damage that is mostly restricted to cortical areas, mainly affecting the primary somatosensory cortex of the forelimb and partially the forelimb primary motor cortex. So when administered acutely, 2-APB reduced the infarcts, total infarct size after permanent ischemia, especially in somatosensory areas when comparing it to untreated mice. At the behavioral level, 2-APV led to a better sensory motor coordination assessed by the grip walking test, as mice treated with 2-APV showed less foot slips with the left forepaw, which is contralateral to the infarcted hemisphere. And moreover, mice treated with 2-APV showed no preferential use of any forepaw after the stroke. We performed additional experimentation to assess if the reduction in the infarct size that we observed in the histological analysis will translate in a preservation of cortical activity. And to that end, we performed somatosensory evoked potentials. After stroke in the infarcted hemisphere of untreated mice, we observed that the cortical activity was almost absent, while in 2-APV treated mice, there was a preservation of the cortical activity. In the case of the contralateral response in the non-infarcted hemisphere, we didn't observe differences between the two experimental groups. So altogether, our histological, behavioral, and electrophysiological results suggest that 2-APV exerts a neuroprotective effect after permanent ischemia. So now we were wondering how 2-APV exerts its neuroprotective effect. It is accepted that after stroke, calcium overload may lead to an increase in oxidative stress due to the dysfunction of the mitochondria, excitotoxicity triggering the release of glutamate, and that triggers the recruitment of inflammatory cells towards the damaged area. All these mechanisms of secondary damage lead to an increase in neuronal death that will increase the infarct size. So we first examined some of these mechanisms. We examined first the in vivo content of superoxide anion in perilesional areas, and we didn't observe differences neither in the perilesional cortex or in the striatum between the two experimental groups. In contrast, when treated acutely with the antioxidant cholesterol neutron F2 after permanent ischemia, there was a reduction in the content of superoxide anion, and this reduction was mostly was higher in the striatum. The neuroprotective effect of this neutron F2 was also observed in histological analysis with a reduction in the infarct area, and at the electrophysiological level, we observed that the cortical activity was preserved in mice treated with F2 in comparison with untreated mice in which there was null response. In addition, we also assessed if there was a reduction in neuronal apoptotic death, and we didn't observe differences between the non-treated and the 2-APV treated mice, but we did observe a reduction in neuronal apoptotic death when the mice were treated with F2. And as I previously commented, the changes in calcium, intracellular calcium, triggered the recruitment of inflammatory cells towards the damaged area. So we performed a immunohistochemical analysis on the cerebral areas surrounding the damaged tissue. And we didn't observe differences in the content of the inflammatory cells and neither in the area of inflammation. Cortical spreading depolarization constitutes a less explored mechanism of injury after stroke. Calcium dynamics in neurons and recently in astrocytes have been linked with cortical spreading depolarization waves. After ischemia, repetitive spontaneous depolarization waves can be detected in the peri-infarct tissue of patients and animal models. And these depolarizations are called peri-infarct depolarizations. The prolongation of these events may enlarge the infarct size. In addition, peri-infarct depolarization causes intense vasoconstriction and hypoperfusion, which will also increase the infarct damage. So this fact, together with the link between cortical spreading depolarization and calcium dynamics, made us to analyze whether there was an influence of the treatment of 2-APV on these cortical spreading depolarization waves. In our lab, we can artificially generate these waves by the application of potassium chloride on the brain cortex. When we administered potassium chloride on the frontal cortex, we observed the generation of a negative voltage shift in parietal locations that propagates to occipital areas. And there we also observed a characteristic phase of hyperemia together with a cortical spreading depolarization wave. However, cortical spreading depolarization waves, the peri-infarct depolarizations after ischemia, are more complex. While some mice develop short depolarizations, others develop longer depolarizations. This variability is also observed in patients suffering from brain injury and has been related to the stochastic nature of these events. More than 50% of untreated mice showed longer depolarizations, while all 2-APV treated mice had short depolarizations. So there's a shortening of the peri-infarct depolarization waves. And since peri-infarct depolarizations affect the perfusion of the brain, we analyzed the cerebral blood flow in the penumbra. For non-stroke mice and sham mice, we got that the cerebral blood flow was relatively stable along the period of recording, but in the case of ischemic mice, we observed these with transient events of hypoperfusion, hyperemia, together with a gradual decrease in the cerebral blood flow. We didn't observe differences in the number of biphasic events and neither in the total peremic response between the two experimental groups, but we did observe that mice treated with 2-APV had a higher residual cerebral blood flow. So our results suggest that the neuroprotective effect of 2-APV is generating a shortening in the peri-infarct depolarizations and an improvement in the cerebral blood flow in the penumbra. Despite these results, for us it is still unknown how the 2-APV exerts this effect on cortical spreading depolarization. One hypothesis it will be based in the calcium modulation that I've been talking about throughout the presentation. And on the other hand, 2-APV is a recognized blocker of gap junctions with high affinity for the neuronal connexin 36, which has been involved in the generation of Peri-infarct depolarizations and ischemic damage. Nonetheless, it is apparently clear that 2-APV it's a modulator of cortical spreading depolarization, as from recent results from our laboratory show that the treatment with 2-APV reduced the amplitude of cortical spreading depolarization waves induced by potassium chloride when 2-APV was administered either intraperitoneally or locally. So the conclusions of our study are that 2-APV exerts a neuroprotective effect on a mouse model of permanent ischemia, that the effects of 2-APV were linked to shortening of Peri-infarct depolarizations and higher residual cerebral blood flow in the penumbra, and that pharmacological modulation of post-ischemia Peri-infarct depolarization opens alternative directions to drive neuroprotection. Finally, I would like to thank all the researchers who have participated in this study, from the Centro de Tecnología Biomédica at Universidad Politécnica de Madrid, from Instituto Cajal and Instituto de Química Orgánica General from CSIC, and from Hospital Ramón y Cajal. Thank you for your attention, and I will be happy to answer your questions.